Hello, everyone. Welcome. Welcome, welcome. Please, if you haven't already, get some food and something to drink for this, our very first lunch briefing back on the Hill in 3 years. So, wow. Thank you for being here. I'm so glad to be here with you. I'm Sarah Dash, President and CEO of the Alliance for Health Policy. And again, thanks all for joining us in person today. The last time we were here in this room was March 6th, 2020. So it definitely feels like kind of an era has passed since then. And it's really good to be back, and we really do so, all of us who are here from the Alliance team with a real renewed sense of urgency about our mission to advance knowledge and understanding of health policy. There's really never been a more important time for these kinds of conversations. So for those of you who are familiar with us, a warm welcome back. For those who've been following us online, great to see you in real life. The Alliance just celebrated our 30th anniversary as an organization, some of you might know. And so as we move forward, some things will stay the same, like our commitment to serving as a trusted educational resource for current and future health policy leaders, which is all of you. And some other things will be new, like some new ways that we're developing kind of behind the scenes to convene meaningful conversations for breakthrough and pervasive health policy challenges. So please stay tuned to the Alliance to find out what's coming next. And really, please share your feedback. We're really a listen-first organization. And we're unique in Washington in that we truly don't have our own policy agenda as the Alliance. We're here to serve the policy community, and we take that very seriously. So definitely, please share your thoughts freely. And I'm told there's supposed to be some slides here, but let's see here. Clearly, like after 3 years of tech, I can't do tech anymore, but that's fine. I'm going to talk about our program. Today is the culmination of our year-long 2022 signature series, which focused on mental health in America. Throughout the past year, we have convened a diverse group of stakeholders to engage in fact-based and experience-infused conversations focused on the question, what would good look like for the mental health care system? And we know that many folks on the Hill and the administration all throughout Washington have been engaged in that very same conversation. At the Alliance's Mental Health Summit in July, we learned about the importance of training and equipping a strong mental health workforce, the need for radical collaboration across sectors and industries, and about the role that innovation can play in advancing patient-centered mental health care. And by listening to you, our bipartisan policy community, we learned that many of you wanted to better understand the world of federal funding for mental health services. Where does the money go? Who does it serve? And what outcomes can we expect? So today, we're thrilled to welcome our expert panel to help answer those questions. And I want to thank our entire team for really pulling this effort together. Please raise your hand if you're on the Alliance team so folks can say hello to you. Thank you, guys. Thank you. Would not be here without them. And I want to thank our signature series sponsors for their generous support that made this series possible. Okay, so as a reminder, today's event is on the record. A recording will be made available on our website, allhealthpolicy.org. You can follow us on Twitter and on LinkedIn. And since this is one of the brand new things, we're now in the year 2023. You can scan the QR code that you see around the room to get more information, get zapped directly to that information. After the speaker presentations, we're going to open the floor to questions. If you still remember how to raise your actual hand as opposed to the Zoom emoji, please go ahead and do that. Someone will come around with a microphone. If you prefer not to ask your question out loud, that is totally fine. We have those green cards that you can write your question on, and we'll be passing them up to our wonderful moderator. So with that, I am so pleased to welcome Catherine Finley, who is a partner at Thorn Run Partners, as our moderator for this afternoon. Thank you for helping me with the slides, by the way. You're already like earning your paycheck here. Thank you. Catherine has been helping to shape federal and state healthcare policy for over 15 years. She's previously served as staff director for the U.S. Senate Special Committee on Aging, where she oversaw committee operations on behalf of Senator Gordon Smith during his tenure as both chair and ranking member. Ms. Finley has also served as senior health policy advisor for Senator Olympia Snowe, where she advised the senator on all health and human services issues, including development and enactment of the Medicare Modernization Act. And her previous roles include legislative director for health and human services at the Southern Governors Association, policy advisor to Governor George W. Bush, and a legislative assistant for the Texas Senate Committee on Health and Human Services. Don't mess with Texas. She received her bachelor's in business economics from Miami University in Oxford, Ohio, and hold minors in political science and international business. So that is quite an impressive background. Thank you so much, Catherine. We're thrilled to have you join us. And thank you for moderating today's panel. So over to you.
Well, thank you all. It's great to be here. Oh, there we go. I'm also not very technologically advanced, so hopefully this goes well. Want to thank the Alliance for inviting me to participate today. This is a topic that is extremely close to my heart. I've been involved in this off and on for a number of years, but certainly sort of came to a crescendo when I worked for Senator Gordon Smith on the Hill, and this was an issue that was very personal for him with his family experiencing suicide of his son. So I think that this is an excellent opportunity for Hill staff to have the chance to sort of learn about behavioral health, all that's been going on. And this is really, I think, a capstone event for the Alliance as they spent the past year looking at and exploring all the different pieces of the puzzle around behavioral health. Today, we're going to hear from three very esteemed leaders in the behavioral health community who are going to talk about federal programs, federal funding, and really how does it all work, both in the administration at the agency level, at the state level, at the organization level, and as we look ahead to this year, and what it's going to hold. So I want to start off by introducing Deepa Avula, who is the Deputy Chief Executive Officer of Behavioral Health Link. And I have to put my glasses up for this one, so I apologize. Behavioral Health Link is a behavioral healthcare company that is focused on supporting states, agencies, and stakeholders with complex crisis care programs. And prior to that, she was the Chief Operating Officer and Deputy Director at the North Carolina Division of Mental Health, Developmental Disabilities, and Substance Use, which she joined after her tenure as Chief of Staff and many other positions at SAMHSA. She holds a master's in public health from UNC Chapel Hill and a bachelor's degree in criminal justice from George Washington University. So we're happy to have her. We also have AJ Walker, who is the policy director at the National Association of State and Mental Health Program Directors. In this role, Mr. Walker guides state program directors through the development and implementation of the association's policy agenda. Prior to joining the association, Mr. Walker was the program coordinator of Indiana's Family and Social Services Administration, Division of Mental Health and Addiction. Mr. Walker received his Master's of Public Affairs from Indiana University School of Public and Environmental Affairs. And certainly last but not least is Brett Beckerson. He is the Director of Policy and Advocacy at the National Council for Mental Wellbeing. Mr. Beckerson has more than 15 years of experience working at the intersection of public health and public safety. At the National Council, he leads the state-based efforts on certified community behavioral health centers, which are known as CCBHCs. Prior to joining National Council, Mr. Beckerson provided strategic guidance on suicide prevention, opioid use disorder, and correctional health at the Pew Charitable Trust. And Mr. Beckerson holds a master's in social work and a bachelor's of art in political science from the University of Michigan. So with that, I am going to turn it over to Deepa. We're very excited to hear what she has to share with us. And again, as we mentioned, or as Sarah mentioned, we will have time for questions at the end. So we look forward to find this helpful, and we look forward to continuing the dialogue.
Thank you so much, Catherine. And it's a pleasure to be here, and thank you all for taking the time to come and listen to this discussion on this really important topic. In over sort of 2 decades of service in the federal government, with the agency charged with leading the nation's efforts to advance behavioral health, one of the things that is very apparent to me and everybody in this room is that great strides have been made. We have really seen Congress take some serious action to really focus on mental health care, to focus on substance use disorders. The 21st Century Cures Act, for example, really refocused SAMHSA and really highlighted the need to focus on evidence-based practices and programs. When we look at things like the Protecting Access to Medicare Act, which really fundamentally kind of laid the groundwork for certified community behavioral health clinics, CCBHCs. What we see now is an integral model in our system of care. We see really kind of steps legislatively that have been taken, that the executive branch has worked with the states and local governments to implement, that have really, really been tremendous. But one of the other things we also know is that there is still so much more to do. So when we look at the data today, we know that over 46 million people in the United States have a substance use disorder. We know that over 57 million people in the United States have any mental illness. And of those people, 25% live with a serious mental illness. So when we look at those numbers, I'm very impressed with the progress that's been made, but it's also really evident that we need to do more. So when we look at SAMHSA's budget, when I first started at SAMHSA, it was somewhere around the low $3 billion. Now it's about $7.5 billion. So we see a lot of investment that's really going into building our systems, building our supports. And at the end, I'll talk a little bit about how SAMHSA looks at those dollars and how it works with states. But one of the things I can say as a former state mental health commissioner is on the ground, those dollars are great. Those dollars are great. Those resources are really helpful. Good policy direction is really helpful. But one of the things we also need to do collectively at the legislative level, at the policy level, at the program level, and we've got a lot of different stakeholders in this room, we have to get our providers ready for that influx of resources. And we've got to figure out how to work together to kind of build the network on the ground in states and communities. And my colleagues here will talk a little bit more about that and how organizations are doing that. But again, I think the money is great and it's a first step, and the policy direction is even better, and that's the next step. But really kind of bringing together all of the different players. One of the other things that I always talk about when I have an opportunity to address an audience like this, everything I just said, you guys all know. I didn't say anything new to you. But what we need to do is we need to figure out how to have this exact conversation, not just amongst ourselves, but among the broader healthcare community that doesn't necessarily kind of want to venture into the behavioral health world. They're a little bit afraid, they're a little bit unsure, they're not sure what it is. There's still a stigma out there in the healthcare community. There's still a stigma out there in just the non-healthcare community. And we have to figure out how to bring all of those pieces together in order to have a really robust dialogue about how to advance behavioral health. So I think all of these things are sort of a great start. And when we look at kind of bringing together community resources, we look at sort of the advent of something like 988, where my organization is really working now to help build the crisis continuum of care. In order to do that correctly, we have to engage all of the family members, all of the community members, the schools, the faith-based community. I always used to say I was not preventing and treating substance use disorders from my office in Rockville, Maryland. That's not where that was happening. That was happening on the ground in communities every day with the people that were interacting with individuals with behavioral health conditions. So I think dialogues like this are super, super important. And one of the things that I really urge us all to do is, take the 3 most interesting things you hear from today and go tell them to people that don't know them. That's what I would challenge everybody to do, because I think that's where we'll really kind of start to really begin to even further expand this dialogue. So, and now I'll turn it over to AJ, who's going to talk a little bit more in detail about what legislatively has happened.
Thank you, Deepa. Can you guys hear me? All right. Happy Friday. Definitely want to begin by I'm going to be highlighting recent mental health legislation, as well as looking at some of the areas that we're focused on for 2023, and as well getting a little bit into 988 as far as the themes that we're looking at for the entire crisis continuum. And then there's my picture. All right. Starting off with the Bipartisan Safer Communities Act. One of the big things that we were excited about was the expansion of the CCBHC demonstration, and Brett will get more into CCBHCs. But this does allow 10 new states to opt into the demonstration every 2 years. So we're excited about the expansion of that service and program. Looking also at telehealth. Telehealth has been very important to the states and the providers, especially with the pandemic. Number one, you're going to hear me say workforce probably 10 times today, but because of workforce, telehealth has been so important to us. Within this legislation, it requires CMS to provide guidance on how they can access or increase access to telehealth via Medicaid for mental health as well as physical health. So definitely this is something that we're excited about continuing to advocate for as well. The next one is supporting access to healthcare services in schools. There's been a lot of focus on children and health and mental health. Part of this legislation requires states, provides them with resources to implement, enhance, and expand school-based health programs under Medicaid. It also gives $50 million in planning grants, as well as establishing a technical assistance center at CMS. And next slide, the last two. The first one is the EPSDT benefit. This is the early and periodic screening, diagnostic, and treatment services, where CMS has to regularly review states' implementation of this and provide technical assistance and identify gaps and deficiencies, and issue guidance outlining the best practices. And last but not least, again, focus on children, pediatric mental health care access program reauthorization. This was reauthorized for 5 years and expands teleconsults into emergency departments and schools. This is administered by HRSA, and it supports state and regional networks of pediatric mental health care teams for teleconsultation training, technical assistance, care coordination for pediatric primary care providers to diagnose, treat, and refer children with mental health conditions. So getting into the most recent, I'm not going to go through every line of this because there's so much, but just it'll kind of give you the idea of how many programs are really funded for mental health through this. Really happy with the $1.01 billion for the mental health grant that our commissioners work on, making sure that they provide and keep their funding for certain programs. And this includes a 5% crisis care set aside. Again, for CCBHC's $385 million, which is a $70 million increase, and the $501.6 million for the Suicide Prevention Lifeline. So important, and that includes $7 million for the Behavioral Health Crisis and 988 Coordinating Office at HHS. So, looking at just some of the other line items on here, there's quite a bit on this slide for children's mental health, as we see children's mental health programs, excuse me, health integration, and then next slide. Looking at suicide prevention programs, Native American and Alaskan Native programs, homelessness, and criminal justice. And then on this slide, looking at some of the science and service programs. So we're, again, very happy. We've seen, obviously, since the onset of the pandemic, our funding has gone up, but our need was always there. It was the only silver lining within the pandemic is that the mental health challenges that have always been there got highlighted more. Funding got highlighted more, and now we see where we can make some definite improvements and expand services for everyone. So one of those actually is the 988 Crisis Care Continuum. This is one of our big focuses for this year. Basically continuing to look for sustainable funding for the entire continuum. That includes the call centers, the mobile crisis units, and the crisis receiving and stabilization. We were excited to hear about the enhanced FMAP through Medicaid for states for mobile crisis. That's one of the steps in providing funding for it. As far as for the call centers, one of the things that the states have been doing has been focusing on fees for cell and landlines. Exact same thing as 911. Unfortunately, only 4 states have been able to pass that legislation right there, but exactly the same. 911 is totally funded. It's through that exact same means. So we're hoping states are able to start taking that up as well. Crisis stabilization and receiving programs. These are the last leg of the crisis continuum. This is where people are diverted away from ERs and jails or inpatient psychiatric higher level, higher cost services. One of the challenges that we're having that we're hearing from our commissioners is around crisis stabilization and receiving programs that would be bigger than 16 beds because they are seen as institutions for mental disease, and therefore in high utilization, high populated areas, they're having real challenges because it's really not fiscally feasible to continuously build building after building of 16 beds because of workforce and all the other challenges. So we're continuing to advocate that those programs are seen for what they are. They are basically community-based, keeping people out of those other restrictive environments and be exempt from that IMD exclusion, because not saying we need to build a 40, 50 bed crisis stabilization receiving program, but they may need a few more beds here and there, and there's no way to add that right now. And 1115s have been a real challenge. The 1115 waiver, which could be accessed to do this, unfortunately, on the mental health side, it's been much more challenging. I believe there's less than 10 1115s that have been approved, where there's more than 30 on the SUD side. So we're definitely looking to see how we can work through those challenges as well. Next up is workforce. Retention and recruitment of mental health workforce. This is going to continue to be a big priority. This is the next one. Prevention, early intervention is something that we began discussing in 2021. This actually focuses on mirroring the SAPT block grant. They have a prevention intervention provision within their statute. Unfortunately, under the mental health block grant, everything has to go towards people who are already deemed SMI and SED. And we think it would be much better to try to start heading off some of those challenges early on to prevent onset for mental illness. See if we can get people early screenings, early evidence-based therapeutic interventions to create a way to reduce future possible crises as well. So we're going to continue to advocate for that to be a part of the mental health block grant. Peer support goes hand in hand with workforce. Basically, we're looking to see how they can continue to grow this workforce. They're an integral part of each treatment team. One of the legislations that we've been following and advocating for has been the PEERS Act. Right now, Medicaid is more in the Medicaid side, but we're advocating for the PEERS Act, which would put peer support under Medicare in collaborative care settings. So we're definitely continuing to push for that as well. And of course, equity and parity. Underserved, all communities should receive what services are needed, and that mental health services are covered in the same manner as physical health. So key themes for 988. First, again, sustainability, consistent financing of crisis for all levels, federal, state, local, and all payers. Technology to ensure all aspects of the 988 system work within each state and community. Again, workforce, reducing barriers and improving the recruitment, retention, and development of all staff levels from peer support on up to licensure. And equity, all populations receive the services they need when they need them and delivered in an inclusive manner for all. And lastly, messaging, a crisis system that can be utilized by all, both mental health and SUD. It's not just mental health. And that the services are connected to the community and are available at all times. So what I'm going to do is now pass it over to Brett and let him talk about CCBHCs.
Great, thanks so much, AJ. My name is Brett Beckerson. I am a social worker by training. My family likes to say I have a master's degree in feelings. But with this presentation, I'm going to get into a lot of different data. But first off, I want to kind of thank folks in the room for advocating for CCBHCs, for championing them, and for providing such robust and much needed funding to advance this program. For folks who don't know about the National Council for Mental Wellbeing, we were previously the National Council for Behavioral Health, kind of changing our name, looking towards that vision of ensuring folks have mental well-being instead of the behavioral health conditions when those conditions are not treated well. So the CCBHC model was established in 2014 by the Protecting Access for Medicare Act. It was established and then launched a few years later in 8 states. Those 8 states had such remarkable outcomes. There was a transition to including not just an opportunity for states in a demonstration, but an opportunity for clinics, so localities, to receive grants. So when we look at this vision for the model, it's to ensure those integrated services. So an opportunity for both mental health care as well as substance use care to be provided in one location with other kind of wraparound and social services that are necessary for someone to achieve recovery or remission from their condition. Cost-related reimbursement, so ensuring that we're able to provide those clinics with the funds that allow them to function like a proper business, to be able to be nimble enough, to be able to be structured in a way that meets their community-specific needs, because statewide, something might be different in my home state of Michigan in Detroit than it is in Alpena, right? There's differences across the state, so how are we able to in a very tailored way respond to those specific needs without risking kind of running into the red financially. And then ensuring that those dollars are being used effectively by high quality care and metrics that let the clinic know, that let the state know kind of what the ROI is for that. Now, across the country and a lot of our members, there's different provider types, right? So there are community mental health centers, there's opioid treatment programs, there's office-based care, there's a number of different diverse types, and what CCBHCs really look to do is have this be a one-stop shop for someone to treat any mental health or substance use condition and be able to achieve recovery and remission. When we think about the CCBHC model, it's kind of broken down into 6 different categories. So I have those over here on the left or right side of the screen. So when we think about staffing, the staffing piece of this is, as AJ had mentioned, really looking at workforce. So what provider types are required to be part of the CCBHC model? There's a list of those within the criteria. SAMHSA is currently modernizing those criteria. Again, they were drafted and established in 2014. We're now in 2022 in a post-COVID world where 988 exists, where other policies have changed. So how do we ensure it's reflecting that? A big part of that is the staffing piece for it. We're looking at accessibility. So this includes both access to care as well as just ensuring an accessible environment. Part of this that I think is really powerful is requirements around immediacy of care, right? So someone raises their hand for care, they have to be able to have care within 10 business days. Normally across the country, it's about 42 days or more. So if you're at risk of an overdose, at risk of self-harm or suicidal ideation, that can be a really long time and can unfortunately put someone at great risk. When we're thinking about care coordination, these are areas where it's not just kind of partnerships within the healthcare centers, right? So an outpatient care facility partnering with a hospital or partnering with a primary care or FQHC. It's also required partnerships with non-healthcare settings. So partnering with schools, partnering with the justice sector, partnering with housing. So that way, if someone comes into the clinic and needs temporary supportive housing, they can help to coordinate that in a way that's much more seamless and doesn't create those delays. A stat that I like to bring up out of New York with care coordination is they had different clinics in New York had different partnerships with schools. And so they were able to embed clinicians within those schools providing services, and they increased access for children and youth by 24%. But what's really cool about this is once those kids were in care, their parents and grandparents were in care. So breaking those intergenerational cycles of untreated mental health and substance use. Similarly, in Oklahoma, they were able to provide iPads to all their law enforcement so that when law enforcement interacted with somebody who may have a mental health or substance use challenge, they could click a button on an iPad and be immediately connected with a clinician that was local. And so they could be able to connect and have more opportunities to divert those needs. On the right-hand side here, you'll see these are the different scopes of services. Really, as I mentioned, it kind of covers what any individual needs. States can layer on top of that what might be necessary. quality reporting so that we're not just tracking as states and localities what are the deaths from suicide and overdose, but are people actually getting healthier, and in what ways, and what does that look like? Breaking it down by populations, breaking it down by different conditions, and then the governance piece kind of ensuring that there's an organizational authority and certification standards, so that way those high quality metrics can be achieved by those clinics. So we do an analysis every year around the CCBHCs, and the numbers continuing to grow. More states are adopting the model. As AJ had mentioned, the Bipartisan Safer Communities Act provides the opportunity for 10 new states to join the demonstration. But there's also those clinics that are receiving grants from SAMHSA that are making really impressive leaps and bounds for care. So we're seeing 77% of clinics are saying their caseloads are increasing, so they're serving a lot more folks. By and large, it's around 180,000 more people are receiving care. And when we think about that, it's a 23% increase in care overall. Now, there's a 30% increase for those that are doing this through a Medicaid route, which Congress provided that opportunity through the Bipartisan Safer Communities Act. And for those who are receiving those dollars as grantees, and the dollars are $4 million for a 4-year period, so $1 million a year, we're seeing about an 18% increase. So really laying a solid foundation for those states to then convert to the CCBHC model. When we're thinking about workforce, we've seen over 6,000 staff hired. When we're looking at kind of from the folks that we surveyed, when we're looking at across the country, over 11,000, and per clinic, we're seeing about 27 new staff positions hired. So that's a pretty big win when we're thinking about the number of clinics that have open positions currently and trying to get folks into care. And similarly, right, for those that did this through a Medicaid route, a higher increase than for those grant-specific areas. I want to highlight one specific state, so the state of Missouri. Missouri was one of the original 8 demonstration states, and so they've been looking at these data for the last 5 years. They've seen a 35% increase in care, and I wanted to take this directly from their site, so I've kind of copy and pasted it here so you could see it. They've been able to increase the number of individuals they've served. They've dramatically increased the number of veterans and active military that they've been able to treat with both mental health and substance use care needs. When we're looking at costs overall, too, from a workforce perspective, they've dramatically increased the number of providers, both peers in particular, as well as those who can prescribe to deliver care. Also, from a cost savings perspective, the ROI is huge. So looking at about a $15 million in savings for the state, and per person looking at that, it's about $484. One of the things I think is really innovative about Missouri is that they had previously established programs that they then built into their CCBHC, one of those being a court liaison program. So they were then able to ensure that for folks who were going to court and who had a mental health or substance use challenge, they could then be able to receive outpatient care in lieu of being held pre-trial. So being able to connect folks to right services, maybe even keeping their jobs, staying with families. So a lot of really much needed and appropriate ways to meet with folks who have those kinds of conditions. So the last slide I have is a slide of just kind of where we're at. The states that are in orange are ones that were a part of the original 8-state demonstration that then added 2 new states in 2020. Ones that are in blue are states that have been innovative in saying we're going to appropriate dollars, whether it be ARPA funds, whether it be dollars from mental health block grants, or even their own state allocated funds to say we're going to take what SAMHSA's provided from those clinic-based grants and then layer on top of that and try to build some infrastructure. States that are in this green or turquoise color have at least one CCBHC grantee within their state. And then ones that have a check mark have made this a permanent part of their program. So in a few months, or maybe by the end of the year, we'll see a lot more of these states kind of changing colors and evolving a bit. We are having active conversations with those states who are gray, who have not had any clinics or have not taken action. But across the country, we're seeing a huge amount of innovation, amount of change, and support for certified community behavioral health clinics. I'll pass it back to Catherine.
So I have been asked to just sort of talk a little bit about how this all works once SAMHSA gets its funding. How does that process work? So SAMHSA's funding primarily comes in really kind of two sort of major overarching forms. One is discretionary funding and the other is block grant funding. In general, SAMHSA has roughly right now about $3 billion, about $3 billion ish in block grant funding, and that funding pretty much goes to the state with the statutory restrictions that are there, but then it is up to the state in terms of how they are going to utilize those funds. So that really is the most flexible source of funding for the states, again, within the statutory sort of confines of the authorization of those grants. The state applies for that funding. There's some monitoring that SAMHSA does to ensure that the funding is going to the right place. But in general, as I said, the state has a real flexibility in using those funds. The block grant is a 2-year block grant. So every year the state gets a new block grant, but that block grant is used for 2 years. And that block grant is for mental health and a separate block grant for substance abuse prevention and treatment. And again, each state, those 2 block grants, that block grant is goes for 2 years. On the discretionary funding side, so obviously Congress has a major role to play here with the appropriations. Once SAMHSA gets its final appropriated budget, it essentially takes that budget, it looks at it and says, okay, what are the things that Congress is directing us to do? So where is it that the agency itself doesn't have the discretion to kind of design the program itself? Largely, the program is pretty much designed by the agency unless the Congress has said you must do these 5 things, or you must do these 4 things, or the funds cannot be used for X, Y, Z. SAMHSA then writes a funding announcement. One of the important things here, for those of you in the room who wish to influence these funding announcements, who wish to hear about what's going on, call SAMHSA. Ask them. Take a look at the budget. Take a look at SAMHSA's budget. Look at where there are not restrictions. Look at where there appears to be flexibility. All the time I used to get calls from people saying, hey, what are you guys going to, how are you planning to issue this CCBHC announcement? How are you planning to issue this Project Aware announcement? Again, nobody gets to dictate that. That's up to the agency to do. But there is a real role for stakeholders to influence that. And so, again, I strongly encourage that you take that role seriously if you're in the position to do so. If you're a congressional staff person, I used to get calls all the time. Same type of question. What is it that you're planning to do? Again, if Congress didn't write it in the bill, it's sort of just a conversation, but that conversation goes a long way, especially if you're a congressional staff person. The other thing, so once SAMHSA awards those grants, generally SAMHSA's discretionary grants are competitive. So there's an application process. Providers, states, whomever the eligible applicants are, have typically 60 days to apply. That's then reviewed by an objective peer review panel. Those grants are then awarded. SAMHSA's funding is annually appropriated, so typically their grants are awarded they're awarded annually, but if you apply for a 4-year grant, for example, you'll get your first year of funding. Each subsequent year, you have to reapply for funding in what we call a non-competing continuation application. So basically, that's where SAMHSA gets to look and see, were these funds utilized in the manner in which we thought they were? SAMHSA uses a couple of measures to do that. They have the Government Performance and Results Act, which basically is Congress's way of saying, we gave you, the federal agency, this amount of dollars. What happened with that amount of dollars? What did you do with it? SAMHSA's programs generally are measured by the national outcome measures. So whether it's for treatment for a mental disorder, whether it's for treatment for a substance use disorder, generally speaking, they're measuring access, retention, criminal justice involvement, access to employment, housing stability, abstinence from substance use, increases in mental health functioning, decreases in ED visits, decreases in hospitalizations. Those are the types of data that SAMHSA has. When we look, for example, at the data that Brett just talked about in CCBHCs, we see in the SAMHSA CCBHC expansion grant program, all of those measures I just mentioned, all of those outcome measures, you see favorable outcomes from the programs. But what this allows the agency to do, because they're getting these data on a provider basis, it allows the agency to do a couple of things. One, again, monitor the funds. These are taxpayer dollars. We want to make sure they're going to the right place and being used for the right things. So monitor the funds for that purpose, for accountability purposes. But then also to look and say, okay, well, this grantee seems to be doing really well with employment. How can we link up this grantee with maybe an underperforming grantee on this outcome? So that data becomes a real tool for quality of service improvement. And the agency is doing that quite regularly. So again, there's an oversight component of that data, and as well as a quality improvement. The data are then also used for data-driven decision-making for future funding announcements, future requests for funding, future budgets. Those those types of data, and again, the agency looks at it on a regular basis, those really kind of yield the next potential set of asks to Congress or the next potential policy direction that the agency wants to go in. One final thing I'll say on this, because it is, as I mentioned earlier, it's a large amount of money. It's a large influx of funds for the states and providers, which again is great. But this money, again, publicly funded programs does require oversight. It requires oversight not just by the agency but also by Congress. And that oversight, and I can tell you as a former federal employee, I didn't love it when Congress called and said we got to do some oversight. It wasn't like the best thing in the world, but it was super helpful because it really allowed us as the agency to kind of hone in on the things that we needed to pay attention to. So that level of oversight is not a bad thing, it's an expected thing. And then it also helped us work with our states and other providers for that as well. So that's a very fast, quick overview of how the SAMHSA grant process works. But and I'm happy to answer any questions or anything like that on that topic.
Thank you all. I hope everybody has found that really interesting and educational. I know there are a number of public policy experts in the room, so we're looking forward to hearing your questions very soon. But I thought I would kick it off. We talked a lot about what has happened over the last number of years in Congress and this renewed, or really almost just this new interest and understanding and appreciation for how important behavioral health is, how important mental and sort of well-being and being able to have access to substance use treatment and behavioral health treatment is. As we look to 2023, understanding Congress is still organizing and still figuring out kind of exactly what they're going to do. As you look at your wish list and you think about what is that one thing that either was left off last Congress or maybe needs to go to the next level, I would sort of pose that question to you all to say, what would that be? If you're a Hill staffer in the room and you want them to keep their eye on one thing, what might that be? You look very excited to answer, AJ.
Thank you for that question. Definitely, I would say do not decrease the level of funding for mental health. No decreases whatsoever. I think it's taken so long to get where we're at. The need has never decreased, will not decrease right now. So that would be my number one wish list, is to keep the level of funding at least where it is. We would always there's always a need for more funding, but definitely no decreases in mental health funding.
Brad, do you have anything to add? Or?
Sure. I think specifically as relates to CCBHC, so kind of maintaining and keeping that funding kind of at those levels, if not higher. I know that we're excited about the increase in funding for CCBHC grantees. There were a number of clinics that didn't get renewed grants, so then they have to think about, well, how do we then move forward when we didn't get that grant again? And is it working with our state? Is it working with Congress? So wanting to make sure that that funding kind of represents and reflects the actual need for those clinics so they can keep that work going while their state looks to apply either for the demonstration or doing it in a more independent route.
Okay. And I would like to see even more support on the crisis system side. I know there's been a lot of support on that, but that's not a sort of a one and done thing. I think that's something that really needs continued investment. On the substance use side, I would say we really just need to caution that it's never one drug, right? So while we'll talk all the time about an opioids crisis and we're really focused on that, as we're laser focused on that, all of a sudden meth is going up. So I think we just need to remember that it's a never, one drug at a time strategy. We really have to think very comprehensively about addressing substance use. I think that's critically important. And then the last thing I would say is really, so when I was a state mental health commissioner, the major thing that really continued to kind of keep me busy, keep my phone ringing, was that individuals with serious mental illness were not getting the care they needed in the community. And it wasn't for lack of want to do it. It was literally just lack of capacity. So just really remembering the treatment needs of the most seriously vulnerable, seriously ill individuals. Those are the individuals that unfortunately the system is still really, really struggling to serve. And I would just kind of keep that in mind as future plans are being made.
Thank you all for sharing that insight. Before I go on to a few other questions that I might have, I want to open it up and give those of you in the audience an opportunity to ask your questions. Yes. I think we have a roving mic.
Did you raise your hand? Oh. Sorry, I'll come back.
Hi, thank you. I'm Schroeder Stribling from Mental Health America. Just a comment on, Deepa, on what you just said a minute ago, that the concern that those who are downstream and the most vulnerable and the most at risk are still not getting the services that they need. One of the things that is always on our mind is that many times those are the folks who are at the intersection with where other systems come into play. So whether that's housing, whether that's criminal justice. And I know you also were mentioning when you talked about how SAMHSA reviews for the non-compete continuation grants, that some of what you're looking at are those social determinants as well. So my question is, from a policy perspective, how is it that we can best collaborate or ally, or what is it that we need to do to make sure that we can tie some of these threads together that are sometimes not under our domain of control directly?
That is a great question. A couple of answers to that. One of the things we did at SAMHSA in the last administration, right before the administration was ending, is we enabled mental health block grant funds to be used in jails and prisons. And the reason was because of this intersectionality between the criminal justice system and the mental health care system. So small policy things like that actually end up going a long way. The other thing, you mentioned housing, and I think it's so important because we're out there sort of talking, we hear a lot about housing first models, which is fine, but it can't be in a housing only model, right? So this sort of goes back to my original point of we spend a lot of time talking to each other. On the state level, what happens is the housing people say, it's not my problem, it's her problem, it's not my problem, it's it. So we need this group of people to actually take time to educate the housing people, the criminal justice people, the sectors that we don't normally interact with. I think that's where we can get some traction. And then also, one other thing is really encouraging federal partners, federal people to work more collaboratively together, which again, when I was in the federal government, I thought we did a great job of that. When I went to North Carolina, I was like, HHS regs don't match HUD's regs, which is causing a major problem on the ground. So I think we need to continue to have this conversation, but not just amongst ourselves. I think that's the key thing that we have to do, because that really does impact all levels, from local all the way up to federal.
Can you hear me? Dr. Myrtle Alexander, Institute for Academic Management. Thank you for a great presentation. Mental health is personal to me because we have it in our family. We've had it for 13 years, and I'm from the UK, so we have a totally different perspective on mental health than the US, of course. My question is to address AJ when you talked about not decreasing mental health. One would even dream of decreasing mental health would be crazy, first and foremost. But then to address Brett, when you put up your screen of your map and your destination states, and I saw two that weren't neither funding or grants. I'd like to know which two states those were, first and foremost. I think it was maybe South Carolina and one up north.
So there's four states that have, so there's 4 states that haven't received any CCBHC grants as either clinic-based grant and haven't appropriated dollars or allocated funds or passed any legislation. That's both of the Dakotas, South Carolina, and Delaware. We're having regular in Delaware, So it's just 3 counties, but still a lot of opportunity there. So there is a lot of conversations happening in those states of different things that are kind of taking shape. I think what's interesting is that there are so many different models. States might think that they just have to choose one. And really in reality, it can be, a number of different models that can help to intersect, because again, what might work really well in one community may work differently in another. And so kind of making sure that states can have that adaptability. CCBHC really does pair well with a number of other kind of models and programs. But those states are kind of moving with different efforts.
Okay, and then the second part is, as we're in the process of launching academies for underserved children, and you hit a nail on the head when you said that once you get it to the children, you then take it to the parents and the grandparents. That is so profound, because you do, and then you reach out to then the other segments of the community. And so funding is only going to be more. You're going to need so much more funding. I mean, literally so much more funding. And so it's going to be a win-win, I think. And so as you reach out, and I think just in this room alone and those that are online, that it is going to be ever increasing. So that's just my point. Thank you.
Hi, Jessica Lego here, intern with the American Psychological Association. Thank you for your presentation today. It was great. How do we keep up to date with what states are doing with the mental health block grants?
Okay. Well, definitely, each state, like from Indiana, they have on their website how to access their state plan for that mental health block grant that they have to submit to SAMHSA. And so you see how it's broken down into each allocation. So I would say definitely going to an individual states. I don't think it's WebBeGuess that they can have access to that. So
yeah, right now there's not a good consolidated way to get that information. So it really is kind of a state by state.
Yeah.
Hi, Eric Scharf with the Depression and Bipolar Support Alliance. AJ, you put up a slide that talked about sort of going forward, but if any of you have your crystal balls there, with the change in how Congress is operating, what is the best guess? I mean, I know we need to focus on appropriations, and certainly there's so much good policy that came through, but how we get it funded. But also, what do y'all see as the other big things that we really have a realistic opportunity for trying to get, in terms of new policy initiatives, appropriations, and then all four of you probably have a perspective on that. So I just curious.
I can. As far as an interpretation of this new Congress, I am totally up in the air as far as how that's going to go. I know that one thing that has been bipartisan has been mental health, so I expect that to continue. Now, as far as new programs and that, there's challenges with spending costs and all that's going on right now. But I would definitely say that at least we have hope that mental health stays bipartisan and continues to have the focus that it does. That's the best I can add to that.
And I think to kind of echo what Deepa had said earlier around kind of polysubstance use and that it's not just the opioid crisis, we are seeing a lot more kind of light bulb moments and folks realizing that medication-assisted treatment doesn't treat stimulant use disorder. There's still a lot of research on that. So folks who have an addiction to a methamphetamine. So we are seeing a lot of opportunities for innovation and research funds and research support from a policymaking perspective to support those who have a stimulus, who are using stimulants like meth and causing overdoses and kind of worsening their conditions. So I think that's another kind of key opportunity when we're looking at other policy areas within the broader kind of behavioral health space.
I would just interject. I do a lot of lobbying work for organizations across town. I've always, for those who know me, I sort of split the world between Republicans and Democrats. I worked for moderate Republicans for a long time. I would note two things. One is the Support Act. There are a number of programs that have to be reauthorized before September 30th. So making sure that you're aware of what those are. And I always stress to everybody, all politics are local. So if you want to engage a member who maybe not personally and outwardly showing that this is an area of interest for them, reach out to their office, get to know their office, get to know their state directors and their state staff, and invite them. If you're an organization and you have a facility, invite them to your facility. If you're working and your board members are Republican leaning or maybe they're business leaders, talk to them, get them to work and engage the members. There are a lot of ways to talk about behavioral health that is not just about increasing funding or, as I like to say, pull at your heartstrings. You can talk about it in a very much fiscal and business perspective of what does it mean when our community loses someone to suicide? What does it mean when my workforce can't show up because they're struggling, or their child or their parent or their spouse is struggling with a behavioral health condition? There are a multitude of business leaders out there who understand behavioral health very much from a business perspective. And I think that when you're trying to meet with members that are new and maybe don't generally or naturally gravitate toward behavioral health programs, you can engage them in a lot of new ways. I will share, Senator Grassley has become very active in behavioral health because the suicide rate among farmers and farm workers is off the chart. And when you go in and talk to Chuck Grassley about farmers, you have his attention. And so it starts those dialogue that then gets you to where you're actually talking about return on investment like CCBHCs. You're talking about opportunities for crisis intervention. Lots of sheriffs are now, and police chiefs are talking about behavioral health because I hear it all the time. Number one expenditure on a sheriff's ledger: antipsychotics, antidepressants, anti-anxiety medication, and counselors that have to come into their jails to deal with individuals who have behavioral health or substance use. And they've become criminalized in that process. And that's what CCBHCs and other programs are trying to do to de-link that. That's where we really need to start talking with Republicans, but all members. And again, we've had conversations with Democrats around IMD exclusion and the connection to incarceration and homelessness. What happens when you don't have a bed available? So there's a lot of ways to do it. Think about it, but think about it from a local level and build up towards your congressional staff in DC and your member of Congress. And I think you'll start to see more success.
And just to build on that from a local perspective. So remember, SAMHSA's budget, $7.5 billion. We have the numbers I said earlier, like a 70 million person problem, right? 70 to 80 million people struggle with a mental disorder or a substance use disorder. That $7.5 billion isn't covering all of those people, right? So that money also is largely local state dollars as well. So you want to influence that level as well. So for example, one of the things in North Carolina that I used to say all the time when I was speaking with the General Assembly, it costs about $30,000. Cost the North Carolina taxpayer $30,000 to incarcerate someone. In North Carolina, we paid about $1,500 for mental health services. And that data then shows, with that $1,500 investment, we got people employed, we got them housed, we got them out of the criminal justice system, we got better mental health. All of that data at the very local. So yes, it's very important to engage your congressional member as well. But don't forget that there's a lot of different funding sources that don't just come from the federal government.
Thanks, everyone. This is Brad Lerner from Elevance Health. And Aaron, and you just teed this up, Catherine. This is from one of your slides you mentioned about the IMD exclusion, which I've been really interested in. That has congressional interest over the last 10 years. But on the narrow view, maybe you could help explain for crisis stabilization. I understand that those are short stays and that there is a managed care rule that allows 15 days. Mm-hmm. So how are these, why are you running into the issue, and how can we help?
Right. Well, we're hearing challenges on the state level that the process, especially for 1115s, is been just a challenge for some reason on the mental health side. As far as managed care, it depends on how close our commissioner is to working and the level that they have of working with the Medicaid director. Sometimes the Medicaid director and the mental health commissioner have a good working relationship and are not separately housed or in some form or fashion. Obviously, our commissioner in Arizona has got the best of both worlds because they're the mental health commissioner and the Medicaid commissioner. So that they have one of the best crisis systems in the country. So it's about getting those silos broken down and seeing how they can work together for those like you said, for the MCOs. But what we're also trying to deal with as far as the crisis stabilization and the issue is the fact that even the 1115s are still temporary. You still have to go back through the process again and renew. And so it just doesn't make sense when you're trying to gear up an entire system. Like 911 took more than a decade. So we don't want to take a decade for 988. So
I think there's two, if I could just add to that, AJ, there's two separate policy questions. One is the IMD exclusion and whether or not it should be lifted in general, right? So that's a whole other policy debate, and I personally think it should be lifted, but there's a lot of kind of conversation on that. The separate kind of thing where crisis stabilization facilities are facing is that they're being deemed IMDs. So the policy direction there is, okay, don't argue about whether or not the exclusion should be lifted. That's a bigger fight. The fight here is, can we get something legislatively or something that says, or with CMS or whomever, that basically says these facilities are not considered IMDs because they're short-term, they're for all of the reasons that they're just really stabilization facilities. And I think that's the debate right now that's kind of hindering states, is that they're dealing with the IMD exclusion on the crisis stabilization facility when their policy argument is they shouldn't be IMDs anyway.
Right, and that's really the only IMD issue we're trying to advocate for. We're not trying to change anything about the statute other than that CMS could possibly take regulatory action on this.
There we go.
Hi, I'm Lindsay. I'm from the Federal Office of Rural Health Policy. I have two questions, but I'll start with the CCBHC question. And equity is a huge piece of the revised CCBHC criteria. However, I've had a hard time kind of figuring out where geographic and underserved fits into all of the revised criteria. Just as far as reaching into those communities, I know that a lot of some of those requirements have been lifted in order to give additional flexibilities. One thing that I've been kind of looking for is some of the data as to where CCBHCs are located, and I haven't been able to kind of find a comprehensive list so that we can kind of do that analysis. And so I guess the second part of the question is that available anywhere? But the first part is just, is there or have you seen significant partnerships or CCBHCs opening in rural underserved areas, and the designated collaborating organizations, have those been helpful in reaching the rural areas?
Great. So a couple of questions in there. So first is, we do have that full list of current CCBHCs, whether they're state certified as part of Medicaid, whether they're grantees. It is available on our website. We do have a CCBHC locator map, so you can kind of see where they are in their county specific. So happy to share that with you, and we'll give it to our friends here at the Alliance to share with everyone. The other piece, so there's two specific clinics that are rural that I'll mention. One clinic that's rural is in rural Oklahoma, northeast Oklahoma. It's Grand Lake Mental Health Center. I think they changed their name to Grand Mental Health Center. One of the things that they did that I thought was really innovative is that for broadband access, they worked with their state to get access to FirstNet, which is the emergency broadband access. So when they're working with somebody, who is 3 hours away, they're able to ensure that broadband isn't broken. If they have an iPad at their home, if they're working connectedly, they're also able to work with different partners, either through a designated collaborating partnership or some other partnership, to be able to meet that person where they're at and provide culturally appropriate care based off that specific community. And that really works well when we're looking at partnerships too with like Indian health populations and different folks within reservations. Another clinic is one in northwest Minnesota, so just south of the Canadian border. Their population is 7 people per square mile, and so they call themselves as Frontier. They've been able to create a lot of partnerships with different counties, with different communities, and one of the things that CCBHC you can build into that cost is the outreach of it. So how much is it going to cost to do outreach to someone who's 3 hours away driving? And so you build that in so that way you're not running into the red financially, but can actually provide those services. And we've been having a lot of those conversations in states like Montana, Alaska, and others, where transportation can sometimes involve like flight. Right. So what is this actually going to kind of look like to be able to ensure that telehealth can be provided to meet that person where they're at, and be able to work with different partners and nonprofits in that area to kind of provide that appropriate care. So and there is a really great analysis that NRI did, which is a division of AJ's team that analyzed that grant program. So we can share that, and they have really good data too.
While somebody walks a mic over, I'm going to ask a question that was put in writing. They would like to have us discuss the expanding role of Medicaid as a source of revenue for the behavioral health facilities, and I would sort of expand that out to, in general, right, beyond just facilities, but in the care continuum.
Sure. Well, I'll turn it on. Medicaid has been and still is the largest payer for behavioral health. Now it's about how to utilize it in creative, innovative ways. Peer support, making sure that's built into the Medicaid system for each state. Looking at how Medicaid can be leveraged in schools. That I believe they're the third largest payer for school services, or for somehow school revenue or funding. So that's kind of been the focus, is especially since the pandemic has began. How can these creative ways under Medicaid be leveraged for new services, different services? Of course, again, there's the issue with Medicaid, but we're not talking about using that in any type of inpatient facilities, of course. But definitely looking at how we can continue. And again, this is what I work well with the National Association of Medicaid Directors, and we kind of have monthly joint discussions about how we can work together with our members and have their members work together so that they can continue to build out behavioral health programs in each state. And I think that's really important, that those two systems work well together.
Yeah, I totally agree with that, and I definitely think in some states there needs to be kind of more education around what that looks like for the Medicaid offices. I think now, just again with all of the increases in the need from the pandemic, we're really seeing more Medicaid offices just take a deeper interest in behavioral health. But one of the things I think would really sort of the visionary thing would be that states are really using their block grants for piloting innovation, for doing really innovative things that ultimately get picked up by Medicaid. That's really where I think if we get to that place, then we're better using the block grant, we're leveraging those funds, we're really then ultimately making things more permanent, and that's where I think Medicaid has a major role to play in that. But so do mental health commissioners. We've got to make sure, and again, I was big on this in my previous role, was making sure that we were not just using submitting the same block grant application we submitted for the past 20 years, right? So if you're representing a state in any way here, or if you're from a state, go and look at that block grant application, and if it is at all reflective of what it looked like 10, 15, 20 years ago, you need to talk to somebody, because the problem has evolved so much, and we need to make sure, and part of doing that would be this idea of thinking through, what if we just use this for like testing things, piloting things, making sure they work, and then trying to get Medicaid to cover them.
And just to add to that, one thing that we do with our commissioners, we have one-on-one quarterly calls with each commissioner in their office, and we share and connect states who are able to do some of these innovative things and see how duplicative it can be from state to state. Not the saying is, you've seen one state, but there are some things that can be more universal where states can figure it out and say, hey, we can do that as well. So we definitely kind of tap into that information sharing.
And just to add on here as well, like from a CCBHC perspective, I think what we see when we're looking at that return on investment in Medicaid is you do see those Medicaid costs go up, but you see costs in other sectors go down, right? With some of the data that we shared, costs around foster care youth in Missouri who are Medicaid enrolled went down because you're able to embed within those spaces where those kids are needing care, so you can have earlier intervention. So I think there's a number of ways too when we're looking at analyzing those data, is it not just looking at Medicaid in a silo, but rather the behavioral health space broadly to look at where and how you can see opportunities of innovation within Medicaid.
The only thing I would add is more of to be on your radar and be thinking about this. Medicaid is the largest payer because people are enrolled in Medicaid who have significant behavioral health challenges. As we look ahead over the next 3 months to a year, Congress decoupled the enhanced FMAP and continuous eligibility for Medicaid from the PHE. So regardless of what happens with the PHE, this process of decoupling and starting redetermination will start in 3 months, 2.5 months. And in that process, I think there is a very important focus that needs to happen in the behavioral health community and the entire community, but the people most likely to fall through the cracks and not get connected into Medicaid coverage continuously, even though they're eligible, are those who have a significant behavioral health condition. They often don't get their paperwork filed. They're more transient than others, so they're moving around. So the letter telling them to get redetermined doesn't ever get to them. So I think this is something we all need to really be thinking about, because during the pandemic, one of the upsides of this policy and of the pandemic prompting it was a significant increase of people being insured, and they're insured in Medicaid. But we know that that's going to change, and hopefully we can reconnect those who aren't Medicaid eligible into other forms of insurance, but also making sure that those who are actually get connected to what a benefit that they're entitled to keep. So that's my public service announcement. All right. And do you have your mic? There we go.
Michael Greer, NCQA. Thinking through, I believe the comments for the new certification requirements for CCBHCs are due today. I'll be working on that later. But thinking through the measures that currently exist, how can we look at the existing certification criteria and ensure that we're aligning across other Medicaid programs, so we're not increasing the reporting burden on CCBHCs as we're looking and talking to the integration of Medicaid, Medicare services, so that we're not being duplicative? How do we ensure that that reporting requirement is not overburdensome and continuing to complicate the care that they're already struggling to provide?
Great question. And there's a lot to say to respond to it. One is that, yes, SAMHSA crafted draft updates to the CCBHC criteria. The comments on those are due today. So they are drafts, so we don't know what will kind of be solidified when they formalize it. But they are looking at evolving some of those quality metrics. A few things that I'll share. One is that you mentioned about the additional burden on clinics. So what we saw in our impact report was that the second highest provider, or the second highest staff type, was a data analyst. So that you don't have clinicians who are providing services having to enter into Excel what those data look like. You have somebody who's actually, that's their job. So you have providers being able to practice at the top of their license and hire people who can do data analysis and do those quality metrics and have that be their job. So you're not overburdening providers to kind of, boil the ocean when it comes to providing care. I think the other thing is looking at the kind of bidirectional communication between both clinics and the state, and then clinics and Congress, and clinics and SAMHSA, so that way folks know what are we already capturing. Because you had mentioned some of the other kind of Medicaid quality metrics, but there's also quality metrics that philanthropies are asking. Say, hey, we're going to give you these monies to do X, Y, and Z because we think it's important. What are you tracking? So having those conversations, so that way they know what's working, and there's not that assumption of what we have and where it goes. And just kind of the final thought is that, the federal government provides a floor, right, kind of policy 101, and then states can layer on top of that their own kind of additional requirements. So what might work really well for North Carolina may not work well for Michigan, or vice versa. So then just kind of thinking through and providing that nimbleness, though, so that you're not kind of forcing a state that doesn't have those needs or abilities to be tracking something that might not be as relevant for them. So I think that the way in which SAMHSA has kind of crafted those additional kind of quality metrics provides a lot of that kind of flexibility there. But again, kind of looking to states, clinics, and organizations to provide those comments.
All right, I have another question here. What opportunities are available for FQHCs to apply to or work with their state for behavioral health interventions?
Yeah, sure. So this is going to vary by state, but generally there are plenty of opportunities to do that, right? Because part of what we want to do is we realize this issue of addressing behavioral health cannot just be left to the specialty behavioral health care field. The field is simply not big enough to solve this problem. So, for example, many of the competitive grants that are announced at the state level, at the state or local level, are available to FQHCs. So some of them are going to be specific to community mental health center or CCBHC, but in general, the providers at FQHC level can certainly apply for those funds. And also HRSA has a number of funds that are obviously available to FQHCs that also address behavioral health. Again, SAMHSA's discretionary funds, that's going to depend on the eligibility that's sort of set forth in the statute. But in general, SAMHSA also funds a fair number of FQHCs that are doing behavioral health services. So there's a big opportunity there, and it's just a matter of looking at these different funding announcements for which ones allow FQHCs to apply for funding.
And FQHCs can also become CCBHCs. There are different payment methodologies, right? So the prospective payment system for FQHCs is different from that for CCBHCs, but you do see a lot of FQHCs becoming CCBHCs, and I recognize I just said a dozen acronyms at once, so I apologize for everyone. But yes, so you can be both. There are different quality metrics. I would say though, a lot of opportunity, it does just involve that communication to the state. So if you are receiving grants that go directly to the clinic, communicating with the state to let them know what's working well, what did you apply for, what are you wanting to do, because that then can help to create opportunities for additional line item funding at the state level, or provide opportunities and innovation for flexibility through grants in Congress.
I see the microphone is in the back.
Yes. Hi, Lindsay with the Federal Office of Rural Health Policy. Just to shift a bit towards workforce, the CAA had, the addition of marriage and family therapists and also mental health counselors, which is really exciting. One thing that I'm also an MSW, and I never got licensed because it's, pretty broad, like across the board, it's 3,000 hours in order to get licensed. Do you see that as a barrier for mental health workforce? And is there, what is the reasoning behind that? Is there anything, movement to kind of shift that a bit?
There's a number of different policy efforts that are taking place at the state level, and then efforts that are happening nationally around state compacts too, so that providers who are licensed in one state can do another. Because I think, as a social worker, that if you're licensed in Michigan, you can work in Michigan, but if you move to Indiana, then you have to go through the process again, and which can, be very deflating for folks, who are already working in an environment where you're kind of working with folks who are at risk of suicide and overdose. And so kind of layering on additional things can be, a bit daunting. There are a lot of opportunities and kind of policy conversations happening at the state level to make sure that you can have more and better access to provider types. And I think the innovations that have happened, as you just mentioned with Medicare, to be able to provide more, it creates that opportunity. For CCBHC, you build in the cost of the staff that your community needs into that, and then you're able to receive that reimbursement rate when you treat someone who's enrolled in Medicaid. So it does provide a bit more kind of that flexibility from a staffing perspective, and the state can then help to require what's included in there. But that doesn't reflect kind of what is, allowable from a fee-for-service perspective with Medicaid. So, there are kind of different conversations happening nationally, but I don't know where folks have landed from that perspective.
Right, and just to add to that real quick, part of what I discussed on one of my slides about workforce is that the states are focusing on how can they develop their current staff to go to higher licensure levels while you're keeping the same staff, but they're progressing in their career. So that type of aspect as well.
I don't see any others, so I'm going to hand it to Sarah, who I think may have a question.
Thank you. I have a question. So this has been such a great discussion. Thank you. So one of my leadership lessons learned heading up a nonprofit is what you don't do is as important as what you do. And we've been talking a lot about the need and meeting the need. I'm curious as leaders yourselves, and like from what you hear from other leaders, like what do you wish could be taken off of your plates so you could focus on the things that need to get done?
Well, social determinants have been such at the heart of many mental health, behavioral health challenges that it would be great for those aspects of each individual's lives to be dealt with at the same time or prior to going into treatment. Because going into treatment, if you don't have anywhere to live, you don't have a job, you don't have any type of way to pay for bills or whatever, your mental health's not going to get better. You have to deal with those things at the same time in order for real recovery to start to happen.
Brett, do you have an answer?
The only thing I could kind of add is, a lot of times I'm kind of translating this to folks who are non-clinicians, right, who don't work in the mental health or substance use space, right? That includes law enforcement, that includes folks who are teachers, folks who work within housing. And I think kind of being able to kind of identify kind of a universal lexicon would be something. So making sure that folks are kind of understanding and working in that capacity would be helpful to ensure that, we're not misinterpreting what the ask is, and we're not misunderstanding what the policies are. Because I think that's where we see a lot of headaches, is where, one person says something and then it's misinterpreted by non-healthcare folks, and that, can create some burdens. And, Medicaid is, fascinating, and both because it is, so important, but also so complex. And so when you're working with folks who don't work in that space, making sure that it's understood. So off my plate would be that translation and interpretation piece would be great.
Which is so funny, because that's the one thing I said we need. So he just took it off his plate. So someone else has to put it on theirs.
Yeah.
One of the things I would say, and I don't know if the answer to sort of taking something off my plate, I don't know about even how to do that. But one of the things I think when I was in both the state and federal government, one of the things I loved most was going out and being able to see programs, talk to providers, see what's actually happening on the ground. And so if that invitation came, then something did come off my plate, so I can go do that. So that's sort of just a kind of another reinforcement of, if you have the opportunity for your state officials or for federal people or for whomever to go do that, they really do like doing that. It's something that's actually very rewarding and really also very informative. So I would just say, keep those invitations coming to people.
I think there may be one question in the back,
Yeah.
and then we're going to have to wrap it up.
All right. Well, hello. My name is Shaquita. And I just want to piggyback on the question about workforce. One of the biggest challenges, we are in 24 states in District of Columbia with our services. And unfortunately, we're dealing with a different generation of workers. And while we talk about innovation and grants, they're great to have for pilot programs. But to really sustain a program that's robust and really to serve the communities and with really intensively home services, we find that the salary rates are very low compared to everywhere else in every other industry. We have workers in Kansas and Kentucky that can go across the street to Wendy's or Walmart and make way more with a licensed degree as a master level degree. Is there anything that at the federal level that you all are thinking about to really address this issue, because it is really a huge barrier for every state that we're in?
So if I can, one of the things that the CCBHC model provides is the opportunity to provide a competitive salary for those providers. So when you do that assessment and you're crafting your prospective payment, you look at what is it going to take to hire someone on board. And so that includes a competitive analysis of not just what does it take to kind of pull a provider out of kind of private practice, but when we're thinking about peers, so people with lived experience, and that lived experience is an expertise, what does it take to pull that person from working at that Wendy's or that Target to then being able to have a job with a greater sense of purpose, but also understanding kind of the risks around kind of, triggering or things around those lines. So we look at, we encourage states to work with their Medicaid divisions to get permission to analyze a competitive salary, not just based off of healthcare, but based off of the industry. Because even things like Amazon and Walmart, they can pay a really high hourly wage. So what do we then do for both salaries, but then also the benefits? So can the clinic provide childcare? Can it provide other vouchers? Can it provide other things that can help to support that individual's whole person needs, to ensure that they not only have a job with a better sense of purpose, that they're serving their community, but it meets their needs individually, not just from a bottom line, but from that whole person perspective. So we are seeing a lot of innovations, and I can share some examples actually out of Kansas as the delta as to where those salaries and hourly wages were increased. But that has happened quite a bit with CCBHCs when you're able to establish the model via Medicaid. With grants, you can provide things like bonuses and things like that can help to incentivize and support providers. But that sustainability piece that you mentioned, so that long-term piece to keep good people in good jobs long-term, that's a Medicaid initiative through CCBHC.
And I would just add to that, this is an age-old problem. It's, the exact example you just gave, I used in a slide 20 years ago that said the Burger King manager makes more than the, so I mean, it was like literally the exact example. So I really think while there have been efforts made, this is a major, 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 major issue. So we can talk all day long about how behavioral health is essential to health and how it's equal and how it's this and how it's that. But unless we start paying for it, right? Passion alone does not feed your family. So we should not expect that, right? That the clinicians that work in our field, they're so passionate that that's not okay. That's not okay. And we should really be in the faces of people that make these decisions about this issue.
All right. And so I'm going to hand it over to Chris Holt with the Alliance, who has a few closing comments.
Good afternoon. Thank you all for being here. And let me ask you to join me in thanking our panel for, I think, a robust and informative conversation. And thank you all for joining with us to exercise these in-person muscles again, for some of us for the first time. I have 2 notes about emails you're going to be receiving from us and 2 notes about upcoming programming. So on that in-person piece, you're going to receive an email after this event asking you to fill out an evaluation. And I would really ask you to take the time to do that, because it's not only important for us as we navigate this new hybrid world of in-person and virtual, to make sure that the content that we're bringing to the audience is helpful, but also that the way that we're delivering it is most useful to you. So please do fill that out when you get that. Second, it has been mentioned, this is the end of the 2022 signature series on mental health in America. It's our last event. But in the next month, we will be releasing a written summary of our programming from this year, or from last year, and we will email that to all of you. It's intended to be an action-focused guide to engaging on these issues, and so we hope that it will be useful to you. And then, if I can get this right, let's see. Nope. Oh, there. I'm sorry. That's the survey. So I'll leave the QR code up for a minute, and then I'll go over to the next slide. We are going to, it's actually my privilege to be able to announce our 2023 signature series. So this will be envisioning a patient-first healthcare system. There's a lot of issues that we want to cover under that, but what we plan to do is work together to identify key attributes of a healthcare system that prioritizes patient-first outcomes, experience, and innovation. So we will be doing working groups. We'll have another summit. There'll be a lot of different ways that you can engage in that, and you'll be getting more information from us about that as we move forward this year. Also want to flag next week, Wednesday, January 25th, is our next event. It's a webinar. It would be titled, What's Coming in 2023? Health Policy Priorities for the New Year. So I encourage you to sign up for that on our website. And then I am just going to take the prerogative of having the microphone to personally thank Catherine, our moderator today, who 17 years ago this month gave me my first job in DC, and myself, is the reason that I work in health policy, but also is the first person in my life who had paid both enough attention and had enough information to recognize the symptoms of clinical depression that were slowly eroding my ability to show up at work and to show up for my family. And not only recognize that, Catherine walked me through the process of getting treatment, practically walked me to the therapist. And so, I want to thank you for that, but I also bring it up because we had a really important conversation today about some very high level ways that we all engage. But it also matters how we show up in people's lives. And so there are really impactful things that we can do individually as well. And I just want to remind us of that as we walk away today. So that concludes our event. Thank you so much. Look forward to seeing you again soon.